مساء الخير، أهلا وسهلا بكم في محاضرة هذا المساء، وهي بعنوان Dementia and Psychosis. يقدمها الدكتور يزن الجباوي، وهو طبيب مقيم في الأمراض النفسية في مركز مستشفى الرشيد، ومن المقيمين الواعدين. تفضل دكتور يزن.
شكرا دكتور وليد على هذه الفرصة. Today's our topic is about dementia and psychosis. The learning objectives of this lecture is to explore the hypothesized neurobiological basis of psychosis in the context of dementia, and also to implement treatments for psychosis associated with dementia. First, these are the DSM5 criteria or diagnostic criteria for dementia. We'll review it in a quick way. So we have evidence of significant cognitive decline from a previous level of performance in one or more of cognitive domains. So as we all know, the cognitive domains mainly are learning and memory, language, executive functions, complex attention, perceptual motor, and social cognition. And beside this criteria, we also have, in order to diagnose dementia, to fulfill the other criteria, which is the cognitive deficits should interfere with independence in everyday activities. At a minimum, assistance should be required with complex instrumental activities of daily living, such as paying bills or managing medications. Criteria C, the cognitive deficit do not occur exclusively in the context of a delirium. And the last criterion is the cognitive deficits are not better explained by any other mental disorder. Now, types of dementia. The most common types of dementia is Alzheimer's dementia, vascular dementia, Lewy body dementia, and Parkinson's disease dementia, frontotemporal dementia, and mixed types. And there are other types but are less common, like alcohol dementia, vitamin deficiency, post-infectious dementia, HIV dementia, and tumor-related, and as well as the chronic traumatic encephalopathy dementia. And there are many other neurodegenerative diseases, but they are less common than the types we mentioned. Regarding the pathology of dementia, the hallmark of most common or most types of dementia is the neurodegeneration. So in dementia, we have a neurodegeneration, and this is why dementia, for this time at least, let's say, it's considered an irreversible disease or a disorder. So it typically involves areas like temporal lobe, as well as involvement of other lobes like parietal, frontal, or occipital lobes. The locations of neurodegeneration process could be cortical, like in case of Alzheimer's disease and frontotemporal dementia, and could be subcortical, like in the case of vascular dementia and Lewy body dementia. This is a PET scan, shows the difference in the metabolism in two subtypes in the dementia, like Lewy body dementia and frontotemporal dementia. So in Lewy body dementia, as we mentioned earlier, it's a subcortical, and in frontotemporal, it's mainly cortical. So we can see here in the frontotemporal, the hypometabolism in the frontotemporal area. And at histopathological level, we have various types of histopathology for different types of dementia, but we have two main histopathological patterns, like the tau immunoreactive neural inclusions, which is the hallmark of different types of dementia, mentioning mainly the Alzheimer's dementia. And we have the alpha synuclein positive, which is remarkable for Lewy body dementia. Now, the time course of dementia. The dementia, as we mentioned, is a neurodegenerative process. So it occurs and progress through a timeline. It mainly it takes from 5 to 10 years, and we have prodromal phase, and it's usually as we mentioned, it's progressive, so it showed gradual advancement. In exceptions for vascular dementia and mass lesions, and in case also of post-infectious dementia. Psychosis usually seen in mid to advanced stage in most of types of dementia, but in exceptions for frontotemporal dementia and alcohol-induced, which the psychosis may present in early stages. Now, regarding the type of psychotic symptoms or presentation, in Alzheimer's disease, 30% of patients demonstrate psychosis and delusions more than hallucinations. Regarding vascular dementia, around 15% of patients showed psychotic symptoms, with almost equal for delusions and hallucinations. The Parkinson's disease dementia, around 50% of patients suffering from psychotic symptoms, hallucinations more than delusions. And in case of Lewy body dementia, around 75%, and hallucinations way more than delusions. The last type is frontotemporal dementia, around 30% of patients expressing psychotic symptoms, and delusions more likely to present than hallucinations. Now, regarding psychosis in dementia, most common hallucinations are visual and less likely auditory and tactile. Most common delusions are from paranoid type. 50% of the patients with delusions and hallucinations reported greater discomfort than those who did not report psychotic symptoms. Presence of dementia psychosis worsens the caregiver burden, including depression, cognitive dissonance, and guilty feelings over placement in a facility. Increased caregiver burden negatively impact the dementia patients and the outcome. Now, regarding the criteria to diagnose psychosis or psychotic condition in dementia, we have, of course, we have to have one or both main psychotic features like hallucinations and delusions, and we have to have a pre-established diagnosis of dementia, and the dementia diagnosis should precede the psychotic symptoms in order to consider it a psychosis in dementia. And the duration of the psychotic symptoms should be more than 1 month, and it should be severe enough to cause disruption or pose a threat to the safety of self or others. And of course, we have to exclude other mental disorders as well as medical conditions in case they can cause similar presentation. So this is a diagram representing the Parkinson's disease psychosis, the diagnostic criteria. As we mentioned, we have to have at least one of psychotic symptoms, hallucination, delusions, illusions, or false sense of presence must occur in the presence of prior diagnosed Parkinson's disease, must be recurrent or continuous for at least 1 month, and we have to exclude the other causes. This is a diagram representing some intrinsic and extrinsic risk factors which aids to develop the psychosis in context of Parkinson's disease. We have intrinsic factors like the disease progression and abnormalities of neurodegenerations, as well as comorbid conditions. And regarding the extrinsic factor, it mainly represents the environmental factors like dim lighting and time of the day, and of course the medication, which is considered one of the main extrinsic risk factors, because as we know, antiparkinsonian medication can predispose to a state of psychosis. And this diagram represents the progression of Parkinson's disease psychosis. It usually begins with hallucinations, and insight is still retained. Then the hallucination progress. Then after that, we have loss of insight. Then the delusion onset. Then the caregiver burden happen and increases. After that, the hospitalization occur. Now, the impact of psychosis in dementia could be on the patient himself and to the caregiver or the family. The impact on the patient himself, like neglect, worsening quality of life, and increase medical care and iatrogenic issues. The impacts on the caregiver or the family represented by family stress and caregiver stress, loss of income, strain on resources, poor healthcare, and worsening of quality life for the whole family. This is a diagram represents some of the pathway of neurotransmitters like the serotonin, which is produced from the RAF nuclei and goes to the prefrontal cortex. We see here the serotonin node. The main receptor there is the 5-HT2A receptor, so the serotonin interacts with that receptor and it sends signals to the ventral tegmental area and to the striatum and as well as the visual cortex. This is the normal physiological process. But in case of dementia, we have a disruption in that pathway, either caused by the various neuropathological processes we mentioned earlier, like the tangles and the plaques, and from Lewy body also, and could be a stroke. So the disruption in this process could produce the psychotic symptoms we mentioned earlier, like if it affects the visual cortex, will produce visual hallucination, and if it affects the ventral tegmental area and the striatum, it will produce the auditory hallucinations as well as delusions. Now, regarding the treatment of psychosis in the context of dementia, we use antipsychotics or mood stabilizers. So the antipsychotics, approximately 1/3 of patients in nursing home are on antipsychotic to manage dementia-related psychosis. The goal of this usage is to manage hallucination and delusions and behavioral manifestations for these patients. Atypical antipsychotics are more common use than the typical antipsychotics. Regarding mood stabilizers, the valproic acid is among the most common non-antipsychotic for management of agitation and behavioral issues in the setting of dementia. So we have here a study compared using the atypical antipsychotics to placebo in order to manage the psychotic symptoms in dementia. So the most common antipsychotic used on 3,353 patients versus placebo, which were used in 1,757 patients. The most common antipsychotics were risperidone, olanzapine, aripiprazole, and quetiapine. The results of this study was reduction of psychosis, and it was noticed to be less effective in severe cases. Minor negative side effects from the use of antipsychotics were somnolence, UTI, and extrapyramidal symptoms, of course. Major side effects were worsening cognitive scores on medications, frequent falling down episodes, increased injuries, and cerebrovascular accidents. Now, antipsychotics and mortality. This is another study demonstrate the mortality effect or for the antipsychotics in the dementia patients with psychosis. It applied to 33,604 patients. All of them were above 65 years old with a pre-established diagnosis of dementia. The antipsychotics used or observed were haloperidol, olanzapine, risperidone, and quetiapine. Antipsychotics with the highest mortality rate were in order haloperidol, more than risperidone, more than olanzapine, and the least one was quetiapine. The highest mortality rate occurred within 120 days of starting antipsychotics, and valproic acid was also studied and carried intermediate risk of mortality. This is the FDA box warning for antipsychotics medications. In 2005, it was put on the atypical antipsychotics for treatment of dementia-related psychosis, and in 2008 it was put on the first generation antipsychotics because antipsychotics was noticed to increase mortality in dementia patients. Now, we have a new drug which was approved for Parkinson's disease psychosis. It's called pimavanserin. It's considered one of the atypical antipsychotics. So it was studied on the Parkinson's disease psychosis. Pimavanserin group demonstrated approximately 6-point reduction in the scale of psychotic symptoms for in Parkinson's disease dementia. And it showed also result reduction in caregiver burden, which is one of our main goals. So improvement in daytime wakefulness and nighttime sleep. And it showed no worsening of motor functioning in Parkinson's disease patients. These diagrams demonstrate the effect of pimavanserin comparing to placebo. We see here and the diagram on the right side, way more patients showed improvement on the pimavanserin, either on one or more points on the rating scales for the psychotic symptoms in dementia. So it was a significant difference. Now, pimavanserin mechanism of action, it actually acts on 5-HT2A as inverse agonist. And it binds to autoreceptors to turn down activity of the 5-HT2A. So as we mentioned earlier in the diagram of 5-HT2A receptor effect on the prefrontal cortex and visual cortex, as well as striatum. So it can reduce the incidence of hallucinations, visual and auditory, as well as delusions. Now, pimavanserin in the Lewy body dementia. Lewy body dementia has the highest rate of psychosis among all types of dementia, 75 prevalence of psychosis. Quetiapine was studied against pimavanserin in a retrospective cohort study in Lewy body dementia, and pimavanserin demonstrate efficacy, tolerability, and safety management of Lewy body psychosis more than quetiapine. Discontinuation, lower of pimavanserin before day 43 compared to quetiapine. It was it showed lower rate of discontinuation comparing to quetiapine. Now, pimavanserin in Alzheimer dementia and related psychosis. We have phase 2 placebo-controlled trials. The primary endpoint was a 30% reduction of psychosis per the neuropsychiatric inventory at scale at 6 weeks. 55.2% achieved primary endpoint in the pimavanserin group compared to 37.4% in the placebo group. Subgroup analysis, patients with severe psychosis demonstrate even greater improvement on pimavanserin. The side effect, regarding the side effect profile, there were no worsening of cognitive and functions in the pimavanserin group. Overall side effects similar to the side effects we mentioned earlier in the Parkinson's disease trials. Like the falls, regarding the falls, pimavanserin was equal to placebo, and regarding discontinuation rate was 9% less than placebo, which was 12%. This diagram showed the difference between, in this study, we mentioned in this study, between pimavanserin and placebo, showed a significant improvement in the groups that was treated with pimavanserin drug. Now, pimavanserin was studied in agitation, aggression, in Alzheimer's disease. It's the Serenity trials. The goal was evaluating the role of pimavanserin in managing agitation and aggression in Alzheimer's disease. They used placebo versus 20 milligram and 34 milligram for 3 months. The studies was discontinued early as it did not have enough patients to detect an effect of treatment. There was extension for this study after that for patient who was successfully completed the Serene trials. 30 milligram and 34 milligram were used for 1 year to assess safety and tolerability. Trial will be completed, but the results should not still not published to this date. Now we have other clinical trial which called the Harmony trials that tested pimavanserin in dementia-related psychosis. It was randomized clinical trials, included patients with Alzheimer's disease, vascular dementia, frontotemporal dementia, and Lewy body dementia. It has a relapse prevention design. Whole number of patients were 392 patients were enrolled, with 217 patients experienced sustained response. At week 8 and 12 were randomized to 1-on-1 placebo or pimavanserin for 26 weeks. The trial was stopped early for efficacy, but the results they got at that stage was 13% relapse in pimavanserin group versus 28% relapse in placebo group, and no negative effects on cognition or motor function in placebo versus pimavanserin. The adverse effect they got from the pimavanserin use in the Harmony trial was headache, urinary tract infection, asymptomatic QT prolongation, and they noticed no negative effects on cognitive or motor functions in placebo versus the pimavanserin group. Now the considerations is pimavanserin is still not approved for dementia-related psychosis despite Harmony trials showing the efficacy of that drug, and will be submitted to the FDA. So they cited a lack of.
لو سمحتوا خلي الميكروفونات مغلقة. السادة والسيدات الحضور لو سمحتوا بمغلقة إغلاق الميكروفونات. تفضل.
So we still have a lack of statistical significance in some of the subgroups of dementia and insufficient numbers of patients with certain less common dementia subtypes, as lack of substantial evidence of effectiveness to support the approval. So in summary, psychosis is seen on most types of dementia to varying degrees. Dementia is likely underreported and therefore undertreated. There are currently no approved therapies for dementia-related psychosis. Current antipsychotics have significant side effects and risks in this vulnerable populations. Pimavanserin is only approved for Parkinson's disease psychosis. Pimavanserin completed the Harmony trial, but it's still not approved for dementia-related psychosis. Thank you.
شكرا جزيلا دكتور يزن. شكرا على هذا التقديم. الحقيقة هو موضوع صعب، والريسيرش أيضا في صعب، خصوصا أن يعني رغم القول بأن هناك several types، أنه في vascular، في Lewy body، في هلا in post-mortem studies there is a lot of overlap. يعني you find Lewy body في vascular dementia, you find tangles في vascular dementia, you find Alzheimer pathology في Lewy body, you find frontotemporal فيها. ففي مشكلة في اختيار العينات. يعني we are not able إنك تجيب coherent group, although يعني as you know clinically we cannot diagnose Alzheimer or vascular. We always diagnose dementia, most probably, most likely vascular or most likely Alzheimer. This means to have 100% accuracy that you have postmortem or biopsy, and we can, as we cannot do biopsy, so we are faced with the fact that postmortem faced with without post-mortem, then selecting the whole group is difficult. The hope, the Bimvanserin has given hope that you may be able, if you have a clear-cut definition of the group, like Parkinson's disease, because these patients are known to have Parkinson's disease for a long time, and then they develop dementia. So we know that this group is a pure histopathology, and accordingly, the results are expected to be clear. The Harmony study have got a group of several diagnoses, and that is unlikely to succeed. The studies that are running now are mostly focusing on certain group, like say traumatic brain or post-head injury or encephalitis, or just Alzheimer, most likely Alzheimer. This makes the possibility of finding medication in these groups better. Although all and black box warning, on daily practice, we do use the neuroleptics. I definitely don't like to use things like haloperidol or even risperidone. I prefer more the olanzapine, quetiapine group, and aripiprazole. Actually, aripiprazole is very much underused in this group, although aripiprazole could improve the agitation without the sedation that sometimes is a burden with the quetiapine and olanzapine. Many patients suffering from this problem, psychosis, agitation, behavioral disturbance, and dementia, need tactful way of management, because the patient is not suffering, but the whole family is suffering. The whole family are in chaos. They don't know what to do, how to manage. For example, most families don't know that you will never have solid 7 or 8 hours sleep in dementia generally. That patient with dementia will be napping dozing on and off all day. And if they are dozing on and off, they are unlikely to sleep 5-7 hours like the family want, because everybody else wants to sleep, and they want this old patient to go to sleep as they do, which is not the case. And sometimes they keep pressure, and many colleagues end up giving doses of benzodiazepine and what's also is hypnotics, which I believe is not right. Part of dementia progress is the disturbed sleep, the interrupted sleep, and the need for a caregiver to be with the patient all day and night. أما والله إحنا مشغولين طول النهار، إحنا تعبانين، فإحنا لازم نلجأ إنه المريض ينام بالليل عشان إحنا الصبح لنا شغل. They have to readjust the family. What the other pharmacological treatment in dementia should be used, like donazepam and memantine. They are standard, and most patients are already on this medication long before the psychosis started. And they are supposed to reduce the chance of psychosis, but they cannot stop it or prevented, patients who have never had this medication, the dementia drugs, most likely end up in severe deterioration with behavioral disturbance and psychosis. So the plan should be that to diagnose dementia as early as possible and to start medication as early as possible. But all this, in my opinion, constitutes some ربع الخدمة. I usually tell patients في الخرف عليكم أن تعلموا أن المشكلة الأساسية هي الرعاية، ومن يقدم الرعاية والرعاية المتزايدة. الرعاية قد تكون في البداية مطلوبة على يعني المساعدة في بعض الأشياء، تدريجيا يصبح هذا صعب، يصبح لابد من وجود شخص مرافق 24 ساعة، إغلاق الأبواب، إغلاق المطبخ، أيضا للبعد القانوني، إبعاد كل الوثائق القانونية والممتلكات والنقود، حتى لا ندخل في قضايا الاستغلال اللي يتعرض لها مرضى الخرف. يعني معظم الأحيان الكير جيفرز ما بيحصلوا على معلومات كافية، وحقيقة يعني ما بيكونوا they were not told what to expect. They should know that the dementia is progressive. We are not able to stop it. We can slow down the progression, but we cannot stop it. And this is the fact that they need to prepare themselves. Who's going to take care of him, where and how. And one of the practices common في المجتمع العربي that the patient is moved from one house to the other. He has to stay 1 week in this son house and then 1 week in this son house. And that adds to his disorientation. Even any one of you, not being demented or old, if you are traveling and you are in the hotel, you get up in the middle of the night and you know the way to the toilet and you go the wrong way, you find yourself lost. So you imagine somebody in dementia, moving him every few days from one place to another with difficult geography and so on. The question about depression, yes, and depression is common in dementia, but early on, when patients are still able to recognize his problem and his forgetfulness, they could present by depression. Many patients in the moderate to advanced cases are thought to be depressed, or the family assume they are depressed because they are just sitting silent and they are not following television or any. Yes, that's true, but that's not because of depression. That's because of their deterioration of cognitive function and inability to follow anything substantial in conversation and so on. These are my comments and reply to some of the questions. Dr. Nizar, go ahead.
Good evening, everybody. Thank you, Dr. Walid, and thank you, Dr. Yazan, for this updated lecture. It was very good. In fact, Dr. Walid covered the missing parts of the lecture, so I will try to squeeze myself and give you some ideas from my personal experience about this subject, which is very interesting. In fact, it's one of the challenges that we face in our everyday life, both from the medical point of view, from the social point of view, and even from the legal point of view. Dr. Walid mentioned the social side. When you have a demented person has 6 or 7 daughters, and the patient is every week in one of the, and I'm pressing the word daughters because Dr. Hanan is with us. Usually the son is not that kind to take the demented person to his house. His wife will refuse to look after the demented wife, demented lady, but the daughters are really keen to do that. Now, the other side of it is another arrangement is every week one daughter comes to the patient's house. And again, that will lead to some disorientation. There is another point in the care of demented patients, which is, for example, you tell them, keep the light on at night, try not to change faces, try not to change the, we have a trend now, a Filipino girl looks after the lady, try not to change the Filipinos who are looking after the demented person, and so on. As far as the schizophrenics and bipolar disorder patients, when they live long enough to become demented, by the way, that is another challenge. Should we continue with the same medications and add the medications that we use for demented people and so on? And we know for sure that these medications at this time when the patient is demented will lead to a lot of problems and complications. So that's another challenge that we have to deal with. As far as valproate was mentioned by Dr. Yazan, he's right, especially when we have, as we know, epilepsy is one of the features that appears with patients with Alzheimer's disease and with other types of dementia. Therefore, in these cases, especially when there is psychosis, epilepsy, a part of the condition called dementia, in that case, maybe valproate will be helpful, but of course, with a short, with a small dose. As far as the another problem that I face sometimes daily with our patients is patients who are living alone, and they are left alone in the daytime. As Dr. Walid said, the family are away, they go to their works and so on, so they are at very high risk. As you know, in the UK, there are social services who visit those patients at their houses, and they see them, look after them, and there is something which is called Meals on Wheels. I think it still exists, where even food is brought to those patients so that they will not, they will not.
Remind you, Dr. Nizar, there are 18 services available in the National Health Service that you can ask for demented patient. Apart from Meals on Wheels, home help, community nurse, you can ask for laundry service, bath service, all of this because patients are cost much less with these services at home than being in institutions.
Sure,
so
definitely.
They're trying to keep them as long as possible in the community.
Yes, and there is home help also, as you know, for the washing the clothes and so on. Yes, you are right. Another point is you said correctly, Dr. Walid, that no single patient has a pure type of dementia. For that reason, the word has changed the name into neurocognitive disorders instead of the word dementia, and it is mild and severe neurocognitive disorders.
Progress.
Depending on that concept. I quite agree with aripiprazole, and I think you and I mentioned this in Dubai together, but unfortunately the problem of akathisia. Personally, I use that drug a lot. In my town, the other psychiatrists started using aripiprazole with those patients after that I started using it on my patients, but the challenge is the akathisia. Another point is there's a concept called pseudo-dementia, because one of the questions was about depression and dementia. Sometimes depression itself could present with symptoms of dementia, but when you treat the depression itself, the patient improves and the symptoms of dementia disappear. So this wasn't real dementia, it was a pseudo-dementia. It is different from a patient, and Dr. Yazan referred to that, alluded to that. It is different from a patient who is already demented. He has signs and symptoms of dementia. With it, he later on develops a depression, especially in those at the early dementia when they still have insight and they know that they are losing their cognitive abilities. And of course, the catastrophic reaction is part of that in the early stages of the dementia. The last point that I wanted to mention, Dr. Walid mentioned something not related to drugs, which is somebody, you have to hide all the money, hide all the documents, etc. Now, something called competency, whether the patient who develops dementia is able to deal with his belongings, his money, his Dr. Yazan mentioned his bills and so on. In the past, when I say in the past, until 4 or 5 years ago, it was all or none. There was something called qaymuma, hujjat al-qaymuma. The family will go to court, and then the man or the woman is taken to the medical committee, and they get an order from that committee that this person is not able at all to deal with his own assets, and they will lose, he will lose all his rights and privileges, and all the money will go to the children. They will presumably look after this person. This has changed now because the person with dementia will not lose all his cognitive abilities at the same time. Now it has been fractionated, hujjat al-qaymuma for certain things, but at the same time he's able to make a will. For example, he's able to buy a car, although they don't drive a car, but I'm just mentioning an example. So this is a new development, that the all or none of the person being incompetent to look after his own assets has changed now. These are the practical points that I squeezed my brain and gave them to you. Thank you very much.
شكرا دكتور نزار. الحقيقة المحاكم الشرعية والكنسية بالأردن لا تسأل عن تشخيص. عادة ما توجه السؤال كما يلي: مدى قدرة فلان على كذا. محدد السؤال. في السؤال الأغلب هو مدى قدرة فلان على إدارة شؤونه المالية. أو أحيانا يكون لغرض آخر: مدى قدرة فلان على توقيع العقود، أو مدى قدرة فلان على كتابة الوصية. في الحقيقة إنه يعني proper evaluation for every question requested by the court is the standard. Just telling the court this patient has dementia, they don't want a diagnosis. They want answer to the case in front of them. The case in one of the family ماخذ وكالة عامة. The other son go to the court and say إنه هذه الوكالة باطلة. السؤال: can he give وكالة عامة؟ الجواب لا. لذلك يعني whenever any psychiatrist see a patient with dementia, he has to document in the on paper that at this hour, 8:44 p.m. to November 22nd, when I saw the patient, he is unable to so and so, because most commonly we get requests later on about somebody who wrote a will or did something, and we are asked by the court هل كان هذا في ذاك اليوم قادرا أو لا. if you are not fixing the date in your filing, it will be a problem. If he was never seen by a psychiatrist and documented by, a psychiatrist, the court will not accept a report from the neurologist or neurosurgeon or any other person. There is a question about using benzodiazepine. Yes, sometimes you may use benzodiazepine, but make sure to use the short-acting one, because long-acting one could lead to more fractures and so on. Valproate usually doesn't cause agitation, although if it's given alone, not with antipsychotics, it may not be helpful for the patient. I don't usually give valproate. Say patient is on donazepam and memantine, and just adding valproate, even if he develops epilepsy, you may need to give something to calm him down, because agitation, yes, could be provoked in some patients by valproate. You all remember that valproate in children cause hyperactivity.
Yes.
And it seems that as we go older, we are more like a children. في سؤال, what is the best drug in demented people? What the best the antidepressant? There was a big recommendation that citalopram has a special effect in patients who suffers from depression and dementia, but that later proved to be not really correct, and there is no difference between various SSRI in depression and demented patients. SNRI are unusually used because SNRI could increase blood pressure, and many old people do have high blood pressure. The question about quetiapine, yes, quetiapine is a very good medication in this group, not even with psychosis, just with behavioral disturbance or sleep disturbance. And quetiapine, as you know, has a very wide range of doses, and you could start from something like 25 milligram and go up to 400 milligram, even 600 if the patient is floridly psychotic. It's the same applies to olanzapine. You can use 2.5 milligram, and you can go up to 20 milligram. Aripiprazole, usually I would start 2.5 milligram and go up to 5 and probably 10. So it's, I believe that dealing with dementia patient, you need experience, for you to be supervised at the beginning, to be able to handle the patients and the caregiver, because many times you see the patient in 10 minutes, but you need 2 hours for the family to get together, and usually there is disagreement. الأشخاص اللي يعيشوا مع المريض في نفس البيت يعرفوا مدى المشكلة. أما أحد الأولاد يعيش في أمريكا وآخر في قطر وواحد في الصين، يتكلموا بالتليفون معه، كيفك، شو أخبارك؟ الحمد لله أنا تمام. كويس، أنتوا شو أخباركم؟ يقول لك هاي وما في شيء. طبعا this is not many times patients keeps on saying no, don't. Our father or mother is okay, until they are really in very deteriorated shape, especially if it is pre-senile dementia. in pre-senile dementia, it's very difficult to believe that this 52 years old lady is dementing and that the dementia has already started 10 years ago. And the question about the role of neuromedicine in dementia or neurologists, well, neurologists in general are not very expert in mental state evaluation and mental capacity. So if they have disability or been trained, there is no problem. But most neurologists don't have this ability to find out the degree of cognitive impairment, the degree of ability, the capacity, mental capacity, and also in the management and how the family, the non-pharmacological aspect and the legal aspect in dementia. The question about trazodone sometimes could be used, and it's useful as a sedative, hypnotic in this group of patients. Will any further questions, comments, تعليقات, اعتراضات؟ دكتور يزن، هل من إضافة؟
لا، حقيقة شكرا لك دكتور على هاي الفرصة يعني والمعلومات الثرية بعد الليكتشر. ما عندي إضافة. شكرا لك.
شكرا جزيلا. شكرا لكم جميعا. أسعدتم مساء. تابعوا مباريات كأس العالم. نراكم في الأسبوع القادم إن شاء الله.
إن شاء الله.
على خير.
إن شاء الله.